Welcome to the afternoon session, ladies and gentlemen. Sorry for the delay, but this is due to the plenary session that took a little bit longer than expected. The overall title and topic of the conference of the session is the HealthTech Innovation Presentation Part 1. Within this session, we will four papers will be presented, and maybe with no creating further delay, we start. And I would like to invite, first of all, Dr. Rafał Buchowicz with the title, with the presentation of the technological advances in medical diagnostic imaging, current status and future perspective.
First of all, thank you very much for inviting me here. It's a great honor and pleasure to be here with you and talk in front of you and sharing some ideas. I'm a radiologist, so I want to share with some current status and future perspective and the advantages in medical diagnostic imaging. Oh, thank you. How I can move to the next slide with this big button here. It's not working. Oh, maybe I need to move further. Okay, so as a radiologist, we are producing so many diagnostic imaging. So, you know, with the current development of the hardware and a plethora of different programs, they are ready to process, and there's a huge space for analysis and refinement of those images. So if I want to point one big advance I can see from the point of view as a practitioner, I would say that the reduction of a time of imaging is a huge improvement, both for the medical healthcare providers, because this increases the revenue for them, for the both scanners, and of course for the patients, which are spending so less time in the scanners. So if we look at the time the patient has to spend for the just brain scan with the contrast, and the 15 years ago, there are data from my department, it was about 60 minutes or more. And due to some advancements, technological advancements in hardware, this time was reduced significantly. But the real breakthrough came lately with the AI, when the patient with the newest advances can rest in the machine, rest in the scanner, in the bore, for the 15 minutes with a scanning of the head, of the brain. I'm talking about MR right now, with a contrast. So this is improvement, huge improvement for the patient, because, you know, the staying in the bore is nothing very impressive for the patient. Okay, so let's go with some very short, to give you some background for technological background of this new advances. I want to make a very short review of the past method. They was rely on the partial scanning for the partial signal of the case space, and also the partial case space processing for the getting signal for the images. So the images which are created that way was very low quality, and the refinement of these images were the bottleneck of the system, because we needed to have so much time to refine these images to the level it can be used by the medical doctors. And what is done, the revolution is done with this modern AI, with these modern networks, is the comparison with patterns which are consist even of 200,000 images, and this comparison give opportunity to find the traces of the real anatomical and pathological images and refine this to the level it can be processed by the medical doctors, by the radiologists. But this stage right now is instant, so it takes not much time to do this. And therefore, there is so big revolution because we can reduce the time at the hardware stage, and after that, we can instantly get the very best quality. And this is example for the EMR, but this is also true for the CT, because here also, if we reduce the dose, we have the grainy and the low quality image. But again, if we use this foundation models designed for the CT, we can refine this image to the level it can be processed by the doctors. So this is very important, especially in CT, because we can reduce the dose very significantly. So this is for the patient safety, I think, very, very important breakthrough. Also, if we are talking about the post-processing stage, because this all was about the creation of the image, but after that, doctors have to go through those images. So current advantages give us opportunity to make a fast triage, volumetric imaging, SM screenings, and not only the old, not only the newest, the newest advancement based on AI are important, but also the classical ones when we use the watershed method, canny operators, texture finding, texture processing. This is also the methods which are implemented in the also programs which are commercial and non-commercial and are used for the tissue classification or topological classification. I'm showing this on the example of a brain, because brain structure, brain shape is so complex, and I think this is best example. We can see the different areas very clear and calculate very clearly the volume, for instance, of the different parts of brain. Also for the functional imaging, this is very helpful because due to tessellation or histogram computation, we can find this area which are metabolically active, and of course they can be also calculated, for instance, in the matter of volume and size. So these old methods, let's say old method, classical methods, which are have their roots in the 70s, are used in these programs. I list some of them because they are very important and gives the medical professional so much aid. But nowadays we have so big hype about AI, and there are so many algorithms which are giving the straight help for the physician. And of course, there is discussion about this because we are talking if they will replace physician or not. So please look how many the programs we have, and most of them are commercial, of course. But what is very important, they are also very helpful, really helpful for the clinician. Here are some examples, of course. There are so many that it's not possible to list all of them, but there are some examples of the programs which are ready even for the phone, yes, for the portables, as some apps, and doctor can have an instant notification about the presence of an infarct or hematoma in the brain if patient was scanned and something was there. Let's say in the patient brain, and sensitivity, specificity of these programs is reported to be very high. This is also true for the pulmonary tissue. So classical radiography, we can there are programs existing for the finding some opacities or tumors in the lung tissue, also with the instant notification. Of course, the prostate with the segmentation for and searching for the tumors. This is, of course, the prostate cancer is most important in men statistically, so this is very also important and a vivid problem. Fractures, yes, MSK. MSK is third branch, which is very important, first discipline, which is very important, covered by the AI, and searching for the fractures is also extremely important because this is present in the OR, and there is significant sensitivity of those programs. So there are some, of course, example only. Maybe also quite important because this is mundane task to search and look for this all arthrosis of the different joints. So this can be held by AI, which can find the arthrosis, which can find osteophytes and count them and list them in the text. Well, which is very important is of course tumors, yes, and the tumors of the breast as a first in woman is I think the most important, and the high sensitivity and specificity of those programs based on AI modules is reported nowadays. With the big tumors, we have also quite a problem with the annotation, with the counting volume. The repetitive counting volume is also between doctors quite problematic. So the newest programs designed to find the tumors and mark them, segmentate them, and count for the volume and area is also very, very helpful for the practicing clinicians. And to summarize this, I want to show you the subspecialties distribution of the current AI products. The first place is, of course, neuro and chest, because neuro, because of this of its importance, yes. So providers, the companies are trying to give us aid with programs which are ready to look and count for the hematomas, for instance, but chest also because of CT and the pulmonary tumors. And if we look at the modalities which are readily covered, it's mostly CT, yes, because CT is maybe not easy, but more easy for the AI than MR, because the borders and the contrast of between lesion and normal tissue is usually very high. And if we look at the diseases, lung cancer, stroke, and the breast cancer are the first three which are most covered by current AI programs. In Poland, which is, I think, very interesting, there are data from the Polish Ministry of Health. There are almost 50% of the hospitals which are claimed to use some of AI program which are involved in the automatic annotation and which aids in the making description for the radiologist, and this is true at least now for the CT. I think this data are very interesting because right now 50% of the hospitals are involved somehow in the AI. Well, and we develop also the register for Poland, and this is register which is aimed to cover the current existing programs, and I warmly welcome you to participate in this task. We want to develop the register for the Polish healthcare providers which are using the AI in the practical medicine. I think it will be very important. It's very important right now and will be very important in the future, because it seems there is no other way for us as medical practitioners. Thank you very much for your patience and attention. Thank you.
Thank you very much for an interesting presentation and looking into the future. Are there any questions? We have time for maybe one short question from the audience. Okay. Yeah.
I have a question concerning sensitivity of this kind of imaging. I mean, AI-aided MR imaging. Because if you have images of so low quality as you showed, you can probably miss some, for example, tiny metastases using just processing the image with a network trained on some other images that may affect the resulting image, which is, well, not a real image as we understand that, but some processed image that may miss some tiny details that would otherwise be identified on the images when the imaging would took longer. How can you refer to that? Because, well, it's I'm a radiation oncologist. I'm involved in treating cancer, and I know that sometimes even for standard imaging, it's very difficult to identify very small metastases in the brain. After processing of low-quality image, this process probably would be much more difficult.
Thank you for this question. If I get you right, this reported sensitivity and specificity of this current AI products is between 60 and 100%. So we have the programs. This is reported even with Professor Strzelecki. We did a review with this very complete of this current programs which are available in the market, and this data are from this review. This is between 64 and 99. So I mean, there are programs which have sensitivity 99%, and the programs which have sensitivity 60%. So almost is throwing a coin. So there is a huge diversity between those. And I think if you have a collaboration and a trust which is gone from your practice, and you can see that the program is working in your department, is a huge advantage for you. But if you will buy some cat in a sack, it may not work. Also, there is some obstacles between the technical characteristics of the programs and the possibilities of detect of the images in your department and on the data which are created with this program was developed. Yes.
Yeah, okay, thank you. Between 60 and 99 is a quite wide range, and well, you have to have some reasons to trust the program. So I don't know if it's credible, if we should believe in 99%, especially when we are talking about so low quality images to be processed by programs. But well, I think it needs to be verified in the clinic before daily use of such programs, because I can believe in 60%, 99% in case of very short imaging, especially when you need sometimes extra dose of contrast agent and so on, and specialized imaging sequences. Well, it's quite difficult to obtain so high sensitivity in this case. Well, thank you.
Okay. I want only mention that all the programs which can be used in a really clinical situation has to be certified. They has to be certified. So the certification process is very demanding, and at least 2 or 3 centers has to test the program according to its sensitivity. So if you have something certified, it might be, let's say, not dangerous to the patients. Thank you.
Okay, thank you very much. We still hope that the radiologists are able to verify the results, because this is still the radiologist is responsible for the diagnosis, right? And not the program, and not the AI, whatever, but still the radiologist. And the question is if they are able really to verify it, particularly if you're talking about very young radiologists who may say, okay, I don't know, the program didn't show the very small, subtle, tiny lesion. I don't see it either because I'm not used to it. I'm not used to diagnosing those problems because the program always does it. And to me, this might be a problem with a very, very, very young radiologist who trust too much in the program because of their own knowledge or ability to read the image.
We still doesn't quit the radiology program in Poland.
Okay, great, great. Okay, and we have to keep it, okay? We have to stay with this. Okay, thank you very much for a presentation.
Thank you very much.
The next presentation will be given by Mrs. Stella Maćkowska, and the title is Text Mining Supporting Computer-Aided Diagnosis of Eating.
Hello, welcome. It's a great pleasure to present part of my PhD dissertation. And in my research, I focus on using text mining and elements of natural language processing to develop some methods that can somehow help diagnosis of eating disorders. Especially, I focus on anorexia nervosa. Sorry for this inconvenience. Before I start the exact presentation, I'd like to show shortly the agenda of my presentation. So first I will give a few words of explanation about anorexia and diagnostic process. Then I move to discussing data collection, research control groups, and the part of text analysis. And in the next part, I will present my research findings, which focus on occurrence of different word categories and key terms related to general overview of the body. And at the end of my presentation, I will present some conclusion. So what is anorexia? Anorexia nervosa is a very severe mental disease which has very difficult and unknown background. Scientists point that the main three factors that are responsible for anorexia, which are biological, psychological, especially the personal traits of a person, and social factors. However, generally in anorexia, patients exhibit strong focus. They focus on keeping a very low-calorie diet, and they do a lot of very intensive physical exercises to maintain their body mass as low as possible. And as you can see in this picture, long-term anorexia can have very tragic effects. In anorexia nervosa, a very important thing is that patients have disrupted body image, which means that even if they look, even if they are in reality very thin, even skinny, they still see themselves as a very fatty person or obese. And of course, we may say that body is something as a source of very negative emotions and a source of sorrow. And of course, it's obvious that long-term anorexia leads to has many medical consequences. It influences all parts of our body, and it's also there are a lot of death cases among patients with anorexia. To give some statistics, the latest global research shows that generally for eating disorders, the prevalence of increase in recent years almost up to 8%. In Europe, it affects up to 0.8% of population, and it affects mainly women, up to 95%, women or young females aged 24 years. In the USA, the age is almost the same, and it affects about 0.3% of the population. And what's very interesting fact is that anorexia influences population in highly developed countries, which can be explained that in those countries we put a high expectation and high social pressure, especially for girls and for women. Some organizations, like for example World Health Organization, use also a daily rate, which is the total number of healthy years that are lost due to disease. And as you can see here, the daily years for worldwide, for 100,000 population, it's almost 30 daily years. For the USA, it's more than 60. For the West Europe, it's more than 70. And in Poland, it's 26. So very sad information is that anorexia has the highest mortality, as I said before, among all mental diseases. And it affects approximately 1% of total population. And the statistics is still growing, and the COVID pandemic also worsened the statistic because of the isolation, because of the limited contact with doctors, and mostly sedentary lifestyle of teenagers. Diagnostic process includes, made of course by the expert, by psychologists, includes some clinical methods like interviews, some experiments applying projective methods, and such methods requires expertise knowledge in the area. And next, psychologists make a hypothesis which must be verified, and they can be verified by some psychological test, and which is novelty when they also can be supported by natural language processing, and applying natural language processing can also reduce the cost of the treatment and shorten the diagnostic process. So next I would like to speak about the research, the part of the research which is focused mostly on analyzing words, analyzing language of patients. And in my research I focus on identifying such features of natural language in written forms which can help differentiate sick people from healthy. The next point was developing tool using or applying natural language processing methods to assess patient condition during diagnosis of anorexia. And the next objective of the research was to facilitate a better understanding of the linguistic mechanism among people with anorexia. So I managed to collect 200 notes, 115 from anorexia patient and 80 5 from healthy girls. All participants came from schools in Gliwice and Zabrze, and in both groups, were asked to write a short note about. We didn't, or I didn't, or the specialist didn't suggest the length of the note. They were asked to write a short note about what do they think about their body, how do they feel with the body. More precise inclusion criteria are as follows. The age of the patients were between 12 and 90 years in both groups. In research group, patient had to be the diagnosis had to be verified by specialists, and other mental disorders had to be excluded. And in control group, the age was the same, and the lack of any diagnostic and other mental disorders. In the criteria also considered average weight, average body mass index. The text analysis included detection of particular part of speech that could be useful for creating a linguistic profile of a sick person, determining frequency of using personal pronoun I and word my, and to detect key terms associated with body image. And in this step, it consisted of 3 approaches. The first step was data preparation. In the next step, developing grammar rules for part of speech tagging. And the final step was statistical calculating the general number of word classes and categorize them into particular group. So the results are quite interesting, and they revealed that anorexia patient language of anorexia patient is somehow altered and is different than from healthy people. I focus on verbs, adjectives, nouns, and possessive adjective word my. And as you can see here in the research group, patients use more verbs and adjectives. The usage of nouns were comparable, and they also use more possessive adjective my. And in the next slide, you can see the result in details. The occurrence of particular word class in notes expressed in percentage. So we can see that verbs were occurred in almost 95% of notes, adjectives in almost 100 of notes, and possessive adjectives were also higher usage among research group. Next, I made more detailed analysis of verbs. I mean the verb form. I focused on present, past tense of general verbs, and present, past, and future tense of verb to be. And as you can see, the present verbs are the result for present verbs in both groups are comparable. But when we talk about past, we can see that patient use more. There were more occurrences verbs in past. General verbs in past terms and to be in past terms. And after consultation with specialists, the explanation for this can be that patient during the therapy become aware of so-called cost of illness. They are aware, they realize that things that these people lost due to the disease. And very often during the therapy, they remind some good memories before the disease, and sometimes the specialist says that it can help during the therapy. In this slide, I just want to point only the abusive usage of personal pronoun I, which also can be explained by this, that people with anorexia are focused on their body on all the actions connected with maintaining the very low body mass. So this is the explanation for this. And once again, here you can see that among anorexia patients, the personal pronoun I occurred in more than 26% of nodes, whereas in control group, almost 6%. As to adjectives, I just wanted to, as I mentioned before, they used more adjectives. And of course, in research group, they use more negative adjectives with negative connotation compared to control group. Another part was detecting key terms, giving the general overview, very general overview of the body. And again, here on the left, we can see words or terms expressed which I found in notes anorexia patient, and the patients were mostly focused on or expressed or relate to the body as harm, hate, fight, lack of acceptance, and they were also focused on the weight, to control the weight, to maintain the weight, and on the right we can see that in healthy people, such terms related to body are quite positive. Despite they have some drawbacks, they are aware of some drawbacks of their body. They feel comfortable with the body, they accept their body, and they treat their bodies with respect. And to sum up, the preliminary research helped me to determine the linguistic profile of anorexia patients, and the research confirmed that anorexia patients have altered language, and as I said before, the abnormal using of some part of speech, especially personal pronoun I, correspond to the psychological traits of anorexia, which is obviously focus of patient body. Thank you very much for your patience and for your attention.
Thank you very much for an interesting presentation. Any questions? We have some time for a question. To me, it's surprising that the control group people do not think about the future. There was 0 in terms of future. They just concentrate on whatever is now and don't think about.
Yes. In this note, I didn't detect any future references.
Mm-hmm.
So maybe they are, because they are the participants who are teenagers, maybe they were mostly focused on what is now.
Yeah, they are stuck on the day-to-day, right? Okay, Stella, thank you very much. Now I would like to pass chairing of the session to our co-moderator, who is Professor Sławomir Blamek.
Thank you very much, Professor. It's my honor to chair the second part of the session. So let me introduce the next speaker. This is Witold Walke. And the presentation will be, I think, more technical, so I expect the number of questions after this presentation to dramatically increase. So, surface phenomena on titanium substrate coated with silicon dioxide used in cardiovascular system. The stage is yours.
Good afternoon. My name is Witold Walke, and I am employee of the Department of Biomaterials and Medical Devices Engineering at the Faculty of Biomedical Engineering of the Salesian University of Technology. I am very pleased to welcome you to my presentation, which will concern issue related to the use of biomaterials for contact with blood. The essence of the problem proposed in the presentation will be to assess the suitability of the silicon dioxide coating for improving the hemocompatibility of titanium biomaterials, in particular commercial pure titanium, grade 4, and titanium alloy used for blood contacting implants. At present, the factors limiting the effectiveness of the use of medical devices in the treatment of cardiovascular diseases include, among others, blood coagulation process and muscle fibrous proliferation within internal walls of blood vessel. They are the effect of not fully adapted physicochemical properties of the surface of the specifies of the blood system. Until now, the mechanism of generating and developing this unfavorable process have not been sufficiently understood. In the literature, results of studies on the evaluation of different coatings for implants introduced into the cardiovascular system indicate the lack of scientific approach. In this context, the questions that also need to be answered is the role of surface processing of biomaterial in the process of shaping the morphological structure and physicochemical properties of the surface layer. These issues are very important, and they determine the course of phenomena at the implant tissue-environment interface. Hence, main purpose of the study was determining the correlation between the structure and physicochemical properties of silicon dioxide layers deposited on commercial pure titanium, grade 4, and titanium alloy, and hemocompatibility used for blood contact. In order to obtain required physicochemical properties of commercial pure titanium grade 4 and titanium alloy, the conditions of their surface treatment were elaborated. The first treatment stage was the mechanical grinding performed on automatic grinding and polishing machine with use of water sandpaper with carbon abrasive. The following stage enabled to obtain the surface roughness, parameters RE max 0.25 micrometer. The second stage was the electrolytic polishing in commercially used bath in room temperature 21 degrees of Celsius in time 3 minutes, which allowed to get the surface roughness parameter RE max 0.12 micrometer. Spreading the silicon dioxide film was implemented using Zabrze method. The chemical and structural homogeneity on the binary metallic oxide silicon dioxide depends on the applied precursor's nature on the obtaining methods, which have an effect on hydrolysis and condensation reactions. From this point of view, the proper choice of precursor and additions used during preparation is very important because it can prevent gel components phases separation. It is essential not only on hydrolysis stage, but also can influence the process proceeded during thermal treatment. The silica precursor used in this examination was tetraethyloorthosilicate, called TEOS, and tetramethylorthosilicate, called TMOS. The rest initial components contained ethanol and water. Hydrochloric acid was used as a catalytic agent. Application of such type of treatment method did not have any influence on the structure or mechanical properties of base material. According to many others, one of the basic criteria for qualification different forms of implants is their corrosion resistance and as a consequence their biocompatibility in solution that simulate physiological fluids. This is why the factors or preliminary suitability evaluation of proposed surface layer with silicon dioxide film were the corrosion resistance examination performed in environment that simulated real conditions. Obtained results of voltammetric examination showed unequivocally that the silicon dioxide film spread in proposed technological conditions provides full titanium base protection against pitting and crevice corrosion also after long-lasting reaction of solution that simulates blood environment. What is more, in order to get a complete evaluation of electrochemical properties of indicated variant of thermal treatment, the examination with use of electrochemical impedance spectroscopy was conducted. The process of spreading the silicon oxide film on titanium base caused a great electrochemical stability of the surface layer, what is proved by a large value of the change transfer resistance. Detailed corrosion, resistance, mechanical properties, and base adhesion results, which were obtained during the silicon dioxide film spreading process optimization, were published as articles in national and international journals. On reaction and immunological reaction connected with biochemical process, beside basic criterion, which is corrosion resistance, the fundamental influence has the chemical composition of the surface layer. This is why in the next examination stage of this elaboration, the quantitative and qualitative analysis of chemical composition of the surface layer was carried out. Above mentioned analysis was performed in order to identify and decompose possibly occurring chemical alloy elements deriving from the base. The examination of the chemical composition showed that the silicon dioxide film spread with Zabrze method with assumed process parameters effectively eliminates the alloy elements from the surface layer and same causes the increase of analyzed biomaterials biotolerance. On the surface of the film independently on the base type, the presence of silicon and oxygen was started. Spreading the silicon dioxide film, both a single phase alpha and D-phase alpha plus beta titanium bases aimed to identify possible difference occurring in these regions. It was stated that the beta phase participation in titanium alloy had an influence of the silicon dioxide film thickness decrease in comparison to film spread on commercial pure titanium grade 4 base, which was specified in ellipsometric spectroscopy studies. It can be caused by smaller tendency of oxide phase titanium oxide film and silicon dioxide film formation in area where phase beta occurs. Introduction of metallic biomaterials, as it was mentioned, results in the possibility of unfavorable phenomena initiation connect with and stopping blood circulation. This is why it is necessary to pay attention on using film with paramagnetic and dielectric properties because magnetotropies of blood elements. Therefore, the measurements of magnetic and electrical properties were the essential part of performed examination. Magnetic force microscopy measurements carried out in AC magnetic force mode showed that independently of titanium base type with silicon dioxide film participation, the domain structure was not indicated. Above mentioned domain structure could testify for magnetization or ferromagnetic properties of whichever sample surface. Any changes of magnetic properties were only connected with base surface topography changes, so with non-magnetic properties occurring between probe and sample. Moreover, measurement with Kelvin probe force mode did not reveal meaningful changes in surface potential distribution. Observed changes corresponded with changes present in images showing surface topography, which means that they are a result of change in surface shape. Topography and roughness of the surface influence also the measurements of phase shift, which did not indicate significant changes in physical properties of the silicon dioxide film. Observed changes corresponded only with the changes of analyzed surface topography of silicon dioxide film. This shows high homogeneity of the silicon dioxide film. Thereby, it testifies correct choice of parameter in the process of film spreading in Zabrze method. On the basis of carried out examination, the obtained results enabled to formulate following cognitive and application generalizations. Passive layer generated on the basis composite of commercial pure titanium grade 4 and titanium alloy during preliminary surface treatment improves its corrosion resistance while is not working as an efficient barrier after 28 days of exposure to artificial plasma solution. for ions, titanium, alumina, and niobium. Penetration that are the part of base material for circulatory system environment. Additional spreading of compact silicon dioxide film using the Zabrze method in conditions that provide its amorphous structure and suitable adhesion to the base, effectively limiting the ion migration of investigated chemical elements after 28 days of exposure in artificial plasma solution. The investigation on morphology characteristic of silicon dioxide film showed the tendency to inherit solid geometrical parameters of investigated surface titanium base shaped by treatment that precedes its spreading process. Elaborated condition of spreading the silicon dioxide film using the Zabrze method provide its paramagnetic properties at homogeneity of the surface potential distribution, what represents the significant requirement of shaping process of the surface physicochemical properties of products having a contact with blood because of magnetropies of blood cell elements. Thank you.
Thank you very much for your presentation. Are there any questions? No questions. I have a question concerning the biofilm you showed on your slides. Could you say something more about that? Because it was a biofilm on the surface of the silicon dioxide coating. What was that biofilm?
Okay. Thank you for your questions. Yes, of course. I think in the future, that in the future, the next examination will be biological test, and the biological test show me what kind of biofilm I have, and the results of biological test were also the basis for selection of correct parameters of the surface treatment realized with use of electropolishing and Zabrze deposition silicon dioxide coatings and the sterilization, which we gently enable to create a surface layer with advantageous chemical, physical, mechanical, and electrochemical properties.
Okay, thank you. It was my next question concerning the microbiological tests, but I understand you haven't done it yet, and it's going to be done in near future, because it will be interesting to see the interaction of the surface with microorganisms like bacteria and fungi, and we still don't know anything about that.
Okay. Thank you. Thank you.
Okay. Thank you. Thank you very much. Let me introduce the next and the last speaker in this session, Krzysztof Dowgierd, and the presentation titled The 3D Planning of Surgical Treatment of Maxillofacial Defects and Deformities.
Hello everybody, thank you for your invitation, dear chairman, dear audience. I would like to introduce you to our daily routine and talk about 3D planning in maxillofacial surgery, treatment in the defects. I am from Olsztyn, from Craniofacial Center, and I'm a maxillofacial surgeon, and I would like to show you something on the end of a 3D planning and all the process of diagnosis and so on. Why we need a 3D planning? We need 3D planning for precisely anatomy, for know what we would like to operate and treat, for proper diagnosis, for preparing osteotomy guides, for preparing individual implants, and navigation and post-op evaluation. Of course, everything combined as a patient-specific solutions. We have some protocols: classic, normal, analog protocol, semi-digital, and full digital protocol. But we don't want to talk about cranial work. We would like to talk about maxillofacial surgery. Maxillofacial surgery combine orbits, midface, mandible, and orofacial area. This is an example of a patient without nothing, without any reconstruction after resection of a mandible in early teenager. It's our initial, 20 years ago, initial planning. It's a I could say semi-digital, because we have a stereotypic model and something like no virtual but handmade planning, and final results not so satisfy. So we decided to go on and use a new technology. Of course, we have a secondary problems. Secondary problems, it's without nothing, with only resection, and we produce a very ill patient, and this patient is rather dramatic. They can't eat, can show a face to the society. So what about process? We have the process is rather problematic, because we have to send the data and analyzing this data and prepare models, guides, implants, and we have to do operation, and we have to control our plan and our treatment protocols. When we talk about a maxillofacial surgery, we have to recognize some kind of surgery. We have a facial skeleton reconstruction, use a free flaps, use the individual implants. Orthodontic surgery, it's a correction of malformation of jaws with teeth. TMJ reconstruction and orodental restoration in difficult cases as well. So the first step, data analyzing and data collections. We should to do a maxillofacial surgeons use a CBCT scans or sometimes normal tomography, and we send the DICOMs, but we have the biggest problem, it's a teeth. So we have to scan it, and we have to establish a digital occlusion as a template for our reconstruction. We don't use now normal impression, teeth impressions like you can see on the lower picture. So data transfer, it's another problem, and how manage it. But a lot of companies give us a lot of possibilities to data transfer. But when we have a data transfer, we should to plan. We can plan ourselves as a individual protocol, but it's consuming a lot of time. The most cases we based on webinars and connection with the engineers. And Google's is useful as well. You can see a short film how we can prepare a reconstruction of a lower jaw with teeth implants, and we can create a 1-day jaw reconstruction after, for example, some malignancies or some tumors resection, and give a patient immediately teeth in one session. Okay, it's a planning. We have we can plan orthodontic surgery. You can see severe facial malformations with prognatism, and we can plan virtually, and we can prepare our individual implants for reconstruction. Preparing of guides and implants, you can see a lot of possibilities to planning the implants and the cutting guides and drilling guides for putting of these implants. It's an example for orthodontic surgery. It's our 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 devices and our equipment, what we get from industries for using of in operation rooms. And during operation, now when we collect everything, we can go to the operation, and it's template guides for cutting in operation theater. We can use goggles. It's a future, and we for controlling our precision of our operation, we can use navigation, and we use operations CT scans as well. And its example, it's a 5-year-old girl with a mandibular tumor. We resect this tumor, and we plan a reconstruction, and we navigated this reconstruction, and we confirm our precision operation during the operation. But we would like to know that everything is a correct position as we plan, so everything it's okay. So after 10 years or more than 10 years, we have a final reconstruction and final results. It's patients completely different than I showed previously. It's a almost normal face and normal growing young girl. Fascial skeletal reconstruction, free flaps plus TMJ reconstruction is one of the most severe patients we did it. You can see a progression of diseases, of mandible diseases, and we plan resected all mandible. She's 70 years old, so total resection of the lower jaw, it's a completely disaster for her and for her life. So we decided resected all mandible and left a teeth. You can see a pathology and pathological disease on TMJ. So we combine TMJ prosthesis, we combine microvascular flap, and it's everything. It's possible thanks to the 3D planning and individual implants, and it's a final result after 1 year follow-up. So everything works very well. Fascial skeleton reconstruction plus individual implants. We use a lot of times individual implants. For example, here it's a Treacher-Collins syndrome. We have a lack of zygomatic bone. So previously we use a bone graft from Calvarium, but now we use PIC implants and implants for floor of the orbit. It's an example of reconstruction of the lower orbit with a Miller syndrome to support of the eye globe and prepare for the next steps for surgery. And it's example trauma reconstruction, low floor of the orbit, thanks to the 3D planning and individual implants. We can precisely put a plate, and we can navigate it, and we can achieve very, very nice functional and anatomical result. Orthodontic surgery, it's a surgery correction of the position of the lower and upper jaw. It's a Treacher syndrome Collins, and it's an example of 3D planning and final result after this planning. As I saw, you can see the equipment, what we need, the devices, what we need to use for planning, for cutting guy, and put individual implants and combine everything together and achieve very nice, very predictable results. The last one is orodental restoration. It's a 60 years patient after radiation therapy in the age of 3 years old. He had any teeth, so we decided to plan supraperiosteal special individual implants for supporting of the teeth. And it's an individual solution for this patient and individual upper and lower jaw. It's a intraoperative view. it's a very precisely, very predictable procedures, and we can give a patient the teeth in one session, and it's a final result, and the patient can chewing and can live almost normal. In conclusion, the use of virtual planning utilizing resection templates and visual-made implants significantly impacts the quality of reconstruction, the anatomical representation of lost tissues, and shortens the duration of the procedures. So we know that virtual planning enhances efficiency and accuracy. Thank you very much for your attention.
Thank you very much for your impressive presentation. Do you have any questions? Again, no? Oh, no question.
I would like to ask about the navigation, the image navigation that you're using. You're using the CT as I have seen on the slide, right?
Yeah.
Where you use the navigation? What is the medical procedure that the image navigation can help you?
During operations, I mean, yeah?
Okay, but in particular, is there a particular procedure that is being used? Or?
For example, you can see orbital flow reconstruction, yes, and we have a special plate, but not we always know how, where exactly we would like to put this plate during operation. So we have a navigation, it's a laser navigation, or it's a so we can put very precisely this plate, and after that we can do during operation a CT scan and confirm that we achieve our plan, and we can combine a STL plan and our CT scan and combine these two pictures and know that we are the right place. So the facial skeleton is so difficult and has a lot of very small elements, and reconstruction should be very precise, especially in pediatric population. So because we have to predict it a little bit grow, and additionally we have a teeth, and teeth it's another problem. So it's a lot of elements we have to combine. So it's a very nice maxillofacial surgery is very nice example when we can use a lot of kinds of technological achievements. So occlusion, teeth, face, bone, and soft tissue. So and navigation and evaluation of our treatment. So it's thanks for bioengineering and our collaboration. It's very important to combine it and go further. Thank you very much.
Thank you. You used a lot of modern technologies. Do you see any room for surgical robots in maxillofacial surgery? Because they are becoming more and more popular, and robotic surgery is in every operating theater almost. Do you see any place for robots in maxillofacial surgery?
Yes, sure. It's the next step. My colleagues from Belgium, 10 years ago, he treated palatal cleft by robots. It's more precisely, of course, it's consuming more time, but I think it's a future of robots. Not robots instead of a surgeon, but with a surgeon. And nowadays, robotic surgery for neck pathology or for tongue pathology, it's almost normal in the high-tech centers in United States, and I think in Poland it will be future for maxillofacial and head and neck surgery as well.
Okay, thank you very much. Do you have any other questions? Thank you. Thank you, Doctor. It was our last speaker, so let me close the session. I would like to thank all speakers and all the participants. Thank you very much, and well, see you next time. Thank you.